Hi everyone, so this is Megan Helfenbein and my project is on a patient I have who presents with Parkinson's disease but has not yet been diagnosed. So his background information: name WB, sex male, current age 72 years old, marital status married, employment status unemployed. His hearing is within normal limits. His cognitive status is that he has a frontal temporal right dementia. And his family life, he resides at home with his wife and has 2 daughters. And his current diet is that he is NPO with a PEG tube. And so, as I mentioned, WB, the patient, has not been diagnosed with Parkinson's disease but presents with PD and has been advised by my supervising SLP to see a neurologist for diagnosis. So, his medical history. WB reports that his medical issues, including his difficulty swallowing, began in April 2021 after a fall. So WB received a fiber optic endoscopic evaluation of swallowing, or a FEES, on May 5, 2021. WB presents with PD but is not being diagnosed, as I mentioned, and has frontal temporal right dementia. He experiences aspiration on pharyngeal PO. He has severe dysphagia and a history of GERD. WB has a weak, low voice and weak cough and difficulty maintaining an upright posture. His surgical history is that he's had a broken hip and femur and his PEG tube. WB experiences difficulty sleeping and walking and presents with an unsteady gait. And WB had a fall in the past 12 months. The fall, I believe, up here that is said to cause the rest of his medical issues. And WB reports that his endurance interferes with his daily activities and that he experiences confusion. And family medical history: WB reports that his father had cancer but didn't specify what kind of cancer. And then this image just shows the different symptoms of Parkinson's. So a lot of them align with the symptoms of this patient: dementia, difficulty swallowing, stooped posture, etc. So what is Parkinson's disease? PD is a chronic and progressive movement disorder. PD causes the malfunction and death of neurons in the substantia nigra, one of the movement control centers of the brain. The substantia nigra produces the neurotransmitter dopamine, which controls movement and balance in the central nervous system. Symptoms of PD include tremors of the hands, legs, etc., bradykinesia or slow movement, rigidity and stiffness of the limbs and trunk, and postural instability, which describes the impaired balance and coordination. And this just shows the brain and the substantia nigra and explains that in Parkinson's patients, dopamine neurons in the nigrostriatal pathway degenerate. So the substantia nigra in Parkinson's disease. So this is just showing a healthy substantia nigra versus a depreciated substantia nigra that you would see in a Parkinson's patient. So Parkinson's disease and swallowing. Aspiration pneumonia is a leading cause of death in patients with PD. Patients with PD may have a decreased ability to inflate the lungs, leading to the decrease in potential to produce high expiratory airflow for cough, so poor airway protection. So high expiratory airflow velocity is created by narrowing the airways and vocal fold deduction. High airflow velocity creates the force to aerosolize material and safely remove penetrants from the lungs during cough. Reduced peak flows during voluntary cough indicate an increased risk of respiratory complications. Weaker respiratory peak airflow reduces the production of shearing forces and weakens the ability to adequately clear material from the airway. This can lead to aspiration pneumonia, which is swelling or infection of the lungs due to food, saliva, liquids, or vomit that is not swallowed but instead gets breathed into the lungs. So Parkinson's disease and dysphagia. Regarding the pathophysiology underlying PD-related dysphagia, dopaminergic dopaminergic as well as non-dopaminergic mechanisms may be involved in the development of swallowing impairment in PD. The dopaminergic basal ganglia system, which is predominantly affected by the neuropathological process of PD, plays an important role in the supramedullary swallowing system. So this image just further discusses dysphagia in Parkinson's and says that symptoms get worse over time in Parkinson's because the disease is progressive, and people may have difficulty walking, talking, and over 80% of people develop difficulties with swallowing, called dysphagia. Swallowing difficulty can be present at any stage of Parkinson's disease and is common even at early stages. However, people with Parkinson's are often unaware of their swallowing challenges. So WB's goals are appropriate, and the goals currently being targeted with him include that the patient will perform pharyngeal exercises 15 times with FAIR plus performance with minimal verbal cues. The patient will improve airway protection via laryngeal adduction and elevation exercises 15 times with FAIR plus performance with minimal verbal cues. And the patient will perform oromotor, labial, lingual resistance / base of tongue exercises 15 times with FAIR plus performance with minimal verbal cues. A vital stim device is applied simultaneously with the swallowing therapy. And WB receives swallowing treatment sessions 3 times a week to reduce the risk of aspiration. So more about vital stim. What is vital stim? Vital stim is the treatment in which clinicians deliver electrical current via externally placed electrodes to stimulate the peripheral nerves that innervate a muscle. In sufficient intensity, the stimulation creates an action potential that travels through the motor neuron and evokes a muscle contraction. So vital stim is controversial. The case supporting vital stim is primarily that evidence proves, when added to traditional treatment, that vital stim makes a statistically significant positive difference in swallowing ability. In contrast, many think the use of vital stim for improving swallowing is not clear, that studies do not support vital stim's marketed outcomes, and that SLP training is insufficient for its use in most dysphagia treatments. Here's a picture of a vital stim device and the electrodes that are used. So one vital stim study is a study by Calabro et al., and it was a study with a post-traumatic brain injury patient. At baseline, this patient showed a severe dysphagia and an impaired corticobulbar excitability. After the first cycle of swallowing conventional therapy, the patient showed a non-significant clinical and electrophysiological amelioration. Instead, he presented a remarkable swallowing improvement after a 6-week period of vital stim training, as shown by either the clinical scales or the fees in comparison to the baseline values after a month of rest, baseline 2. In addition, the patient was able to safely eat even solid food, so that the PEG was removed. Interestingly, a restoration of the corticobulbar excitability was noted, as evaluated by RPAS after effects. So one other vital stim study, which is also kind of in support of it, is a study by Sun et al., 2013, which demonstrated that combined vital stim, fees, and traditional swallowing rehabilitation showed the potential to improve swallowing function in stroke patients with moderate to severe dysphagia. These benefits could be maintained for at least 6 months and up to 2 years. Patient satisfaction rate was high, and there were no serious adverse events. And the results from this case series provide support for this promising combination. And further studies are warranted to help establish the future clinical utility of this novel combination therapy in dysphagic patients. And this just shows the 2 channels where the electrodes on a vital stim device get placed. And that is it. Thank you.